Good morning, friends. My name is Dr. Sunil Sabale. I am a pediatric neurologist and I am an associate professor in Department of Pediatrics. Today, we are going to discuss one of the important topic in pediatrics as well as pediatric neurology, and that is epilepsy. So, epilepsy is one of the commonest problem which we face in a pediatric neurology practice. Almost 70% of patients which comes to the pediatric neurology are of epilepsy, and of all the epilepsy, 70% has its onset during childhood time. So childhood period, pediatric period is important thing as far as epilepsy is concerned, and it has a very detrimental effect on the child's development. So it's very important that we should have early diagnosis and treatment of this kind of patients. So what is epilepsy? Epilepsy is a chronic disorder of brain with propensity to have a recurrent unprovoked seizure. Okay, so if there is a single seizures, we may not call it as an epilepsy. It has to be recurrent and it has to be unprovoked. For example, if there is a febrile seizure or if there is a trauma and the patient has a seizure, then we may not call it as an epilepsy. It is a single isolated seizure. So one should differentiate between various terminology. Certain terminology like seizures, convulsions and epilepsy are used interchangeably. So what is a seizure? Seizure is an abnormal clinical event due to excessive and abnormal electrical activity of brain. Okay, while convulsion is a motor part of seizures which we see, and epilepsy is a chronic disorder of brain with propensity to have a recurrent unprovoked seizure. For a practical purpose, two seizures 24 hours apart are considered as an epilepsy. Now, if a child present with a history of seizure or convulsion, then how to approach? So we have to approach this patient in a stepwise manner. First is a history taking is very important. Second thing, we have to rule out a seizure mimic. So what are the seizure mimic? These are the clinical events which look like seizures but they are not seizure. Okay, so we have to rule out this seizures mimic. Then once we think that it is a seizure, then we have to classify whether it is a focal or generalized seizure. Then next is a syndromic classification, then etiology, treatment and counseling. So we'll go stepwise manner. First is a history taking. History taking is very important. One has to take a history from a person who has witnessed that clinical events. We have to ask whether the seizures occur in sleep or in awake state, because certain seizures occur in sleep, like Rolandic seizure, or certain seizures occur during when the patient is awake, like we have idiopathic generalized epilepsy with myoclonic jerks, like juvenile myoclonic epilepsy. So these seizures occur during awake state. We have to ask what are the precipitating factor. For example, febrile seizures are precipitated by fever. Idiopathic generalized epilepsy is precipitated by sleep deprivation or flashes of light. So we have to ask if there is any precipitating factor or not. What is the position of a patient before the event? For example, if the patient is standing for a prolonged period of time and the patients fall down and become unconscious, then it may be a syncope. Okay, or if it occurred during sitting and lie down position, so it may be a seizure. If there is an aura, so what is an aura? Aura is a part of a seizures which patient remember. For example, few patients may have some visual aura, like they may see some flashes of light or they may see some abnormal image, and then they will have a seizures, or there may be a graying of vision, and then the patient may throw seizures when it originates from occipital lobe. If it originates for temporal lobe, then they may have some rising epigastric sensation. So aura is a part of seizures which patient remember, and it helps to classify seizures, because if there is aura, it indicates there is a focal onset of seizure. Then we have to ask what exactly occurred during seizure, whether seizures affect a particular part of the body or it affect the whole body. If it affect a particular part of a body, then it is called as focal seizure, or if it affects whole body, then it is called as generalized seizure. Then what occur after seizures, whether patient is normal immediately or he become drowsy, he go into sleep, whether he has any focal neurological deficit like hemiparesis or weakness of any part of the body after seizures, then we should think that it is a focal onset of seizure. One has to take a detailed family history, because the genetic epilepsy are autosomal dominant, and there may be a history of seizures in the parents or in any relative. So we have to take the history of epilepsy in family. Birth history and milestone is important, because any trauma during birth like birth asphyxia or postnatal hypoglycemia or meningitis, or patients of low birth weight, IUGR, any events which results into the insult to the brain may cause seizures at that particular time or later on. Then next comes the clinical examination. Clinical examination is very important. One has to see a patient in a totality, and the clinical examination may give clue to the diagnosis. Now this patient presented with seizures, and when I saw the patient has this hypopigmented patch on his body, multiple patches. So this patch is called as Ashley macule, which is seen in tuberous sclerosis. So if you do general examination, then you may diagnose it as a tuberous sclerosis straight away. Again, you can see there is a multiple this blackish acne like spots on his face. It is called as Ashley, this is called as adenoma sebaceum. So again indicate tuberous sclerosis. Okay, so you can see a lot of adenoma sebaceum and this hypopigmented patch. It is Ashley macule. Again, this patient presented with seizure. On general examination, he has this hyperpigmented patches all over the body, and this is cafe au lait spot, which is present in neurofibromatosis type 1. Again, a big cafe au lait spot you can see. So it's very important to do a general examination. Again, the subcutaneous nodule in neurofibromatosis type 1. Then you have to see whether there is any focal deficit, hemiparesis, or there is a diplegia. So it indicates that there is underlying cause, and this patient has focal onset of seizure. After taking clinical history and doing general examination, one should rule out whether it is a seizure mimic. I have told you, seizure mimic are clinical events which look like seizures, but they actually are not seizures, and patients are erroneously diagnosed as seizure and put on multiple anti-epileptic drugs with its side effect, and it is not effective at all. So there are certain seizures mimic which we see in a clinical practice which look like a seizures. So this is called as a benign sleep myoclonus. Okay, so in this patient get a sudden jerks which last for a fraction of a second during sleep, and otherwise patient is neurologically normal, so it's not a seizure. Then this myoclonus may occur during awake state, but patient is neurologically normal, EEG is normal, then this is not a seizure. Third problem which we commonly get in a clinical practice is a breath holding spell. The parents may tell you that the patient has uprolling of eyeball with tightening, but when you ask what occurred at the onset of seizure, then they will say that the patient cries, then he holds his breath, then there would be perioral cyanosis, then patients become unconscious, then become tight. So you have to ask what occurred before seizures. If it is precipitated by crying, then it is a breath holding spell and it is not seizure. Next is a pallid breath holding spell. This is also not seizures but look like seizures, means patient suddenly fall down, become totally white. Okay, his heart may stop for a few minutes, for few seconds, and parents may think that the patient is dead, but again within few seconds or minute the patients become normal. So it is here also, it's precipitated by acute trauma, means patient has some bang his head or somewhere, and then he falls down, then it is this clinical event occur. Then a night terror, means patients wake up in a sleep, become very cries for 10 to 15 minutes, inconsolable cry, and patients again go to sleep, and next day patient doesn't remember what has occurred previous night. So it's a night terror. Narcolepsy, cataplexy. Here narcolepsy, there is excessive daytime sleeping. Mean patient will fall asleep in front of you, and you may think that this patient has become unconscious or not unconscious. Cataplexy, again sudden loss of tone and they fall down. So these are not seizures. Syncope, common things which we get in a practice is child is standing for a prayer for a prolonged period of time, and he suddenly fall down, become unconscious. So these patients are erroneously diagnosed as a seizures, but they are not seizures, they are syncope. Migraine is also one of the important differential in seizures. Here the migraine with aura, especially the visual aura, may look like a seizure. Okay, so one has to rule out this seizure mimic before one come to the diagnosis. So what are the points which tells you that it is a seizure? If in seizure eye has to be open, okay, there may be eye deviation, there may be head deviation, there may be incontinence of urine or stool, tongue bite. So if these are present, then it indicates that this patient may has seizure. Other things like unresponsiveness, confusion, tonic-clonic movements will be also suggestive of seizures. Once you diagnose that it is not seizure mimic, it is seizure, then you have to classify it into whether it is a focal seizure or it is generalized seizure or it is unclassified seizure. Now in old classification, the focal seizures was classified into simple partial seizures, complex partial seizures, or simple partial seizures or complex partial seizures evolving into secondary generalization. So here only one part of the body is affected, while in generalized seizure whole body is affected, like tonic seizures, clonic seizures, generalized tonic clonic seizures, okay, absence seizures, in which the patient there is a loss of consciousness or awareness for few seconds, not more than 30 seconds, and he becomes normal, and it occurs multiple times per day. Myoclonic seizures means there may be a sudden jerk in a part of body or whole body. It occurs in juvenile myoclonic epilepsy. Atonic seizures means patients is standing or sitting and he suddenly falls down, then it is called as atonic seizures. Or infantile spasm, again this is also sudden jerks, also called as salam attack. Now again there is a new classification of seizures called as syndromic classification. Here what is a syndrome? The syndrome is a cluster of signs and symptoms, and based on age, what occur during seizures, etiology, anatomy, precipitating factor, severity, chronicity, diurnal variation, prognosis and response to treatment, the seizures are classified into 4 groups. First is localization related epilepsy, second is generalized epilepsy, third is epilepsy or epileptic syndrome undetermined whether it is a focal or generalized, and these are spatial syndrome. And each syndrome is further classified into idiopathic or symptomatic. Idiopathic is also called as genetic, means there is a genetic basis for the epilepsy, and symptomatic means there is some problem in a brain, there is some injury to the brain and it has resulted into seizure. Now how to investigate when a patients come with the case of epilepsy? Now first investigation is EEG. EEG is called as electroencephalogram, and it has to be done as early as possible, because if you do early, the chances of getting abnormality is quite high. The EEG will help you to diagnose whether it is seizure or not. Okay, but it is not all or none phenomenon, because if patient is having epilepsy, EEG may be normal in 50% of the patients during first record, and with repeated record you may see abnormality. Or if EEG is abnormal, it doesn't mean that patient has epilepsy. We have to correlate clinically, and then you have to come to the diagnosis and start the treatment. So EEG helps to identify whether it is seizure, help to classify seizures, also sometimes prognosticate and monitor the treatment. Next is neuroimaging. Now preferably MRI brain with epilepsy protocol should be done. CT scan should be done in case of acute trauma, or patient is having recurrent seizure, or it is not possible to do MRI. In that case you have to do CT scan. Otherwise MRI with epilepsy protocol is the investigation of choice. Depending upon the age of patients, we may do some blood investigation. For example, if the patient is neonate, you may do serum calcium, sugar, electrolyte, magnesium, CBC. Okay, so to rule out hypocalcemia, hypoglycemia, hypomagnesemia or hyponatremia, we have to do investigation. But if the child is older, then there is a less chances that the patient has hypocalcemia. Lumbar puncture, CSF examination has to be done if there is a history of fever and the patient get convulsion and you are suspecting there is a meningitis. That case you have to do lumbar puncture to see CSF examination. Now how to treat these patients? Now the aim of treatment is complete seizure control but without adverse effect. Okay, so we have to prevent the recurrence of seizures and prevent the trauma or injury associated with seizures. That is the aim of patients, but we have to treat so that patients is the seizures are controlled but patient doesn't have any side effect of a drug. So that's why if there is a single seizures, then we may not treat, but if patient has a 2 seizures, then we may treat. Or if there is a 1 seizures and you think that there is some neurological problem, there is a EEG is abnormal or MRI abnormal, then you may treat this patient during first seizure itself. Okay, so what is a risk factor of recurrence? So I have said if there is a pre-existing brain abnormality, for example because of birth asphyxia or because of intracerebral hemorrhage or hypoglycemia, or there is some CNS cortical malformation, so this patient has a high chance of recurrence of seizure, so you may treat at the first seizure itself. Okay, focal neurological deficit, abnormal EEG, tumor, status epilepticus, family history of epilepsy, previous febrile seizure, abnormal neuroimaging. Okay, so these are the findings which indicate that this patient has high propensity of developing recurrent seizures, so you have to treat these patients even if if there is a first seizure. Now how to give the anti-epileptic drugs? We have to take lot of things into consideration. First is a type of seizures. If it is a focal seizures, then we may treat with the carbamazepine. If it is a generalized seizures, we may treat it with valproate. So depending upon the type of seizures, then we have to decide the anti-epileptic drug. Epilepsy syndrome, for example, if there is a juvenile myoclonic epilepsy, then sodium valproate is a treatment of choice. Okay, you cannot give carbamazepine. So epilepsy syndrome is very important for the treatment. Age of the patient, gender and ethnicity. For example, patients with if the patient is less than 2 years, then sodium valproate should be used with caution because it may cause fatal hepatotoxicity. Gender, we should not use valproate in a adolescent female because valproate may cause polycystic ovarian disease, hair fall and weight gain. So depending upon the gender, we have to choose the anti-epileptic drug. Ethnicity, For example, certain ethnicity, for example, Hans Chinese, have certain HLA type which predispose them to the hypersensitivity syndromes to carbamazepine. So if you do a genetic test and if you find that a certain HLA type, then you avoid carbamazepine in them because it may cause Steven-Johnson syndrome. Pre-morbid condition, if patient is obese, then we may not use valproate because valproate may cause weight gain. Concomitant illness, for example, if patient has hepatic disease, hepatitis or hepatic failure, then we may not give a drugs which are eliminated to the liver. For example, we may not use valproate in a patient with hepatic disease. Okay, co-medication, so we have to see whether the patient is other medications because there may be drug interaction, because phenytoin sodium or carbamazepine are cytochrome P40 enzyme inducer. So it may increase the metabolism of drugs which are also metabolized by cytochrome P40 450 enzyme. For example, if patient is concomitantly taking OC pills, okay, they may, other drugs like anticoagulation and all, so it may increase the metabolic rate of these drugs and they may become ineffective. Pregnancy potential, certain drugs may cause teratogenicity. For example, sodium valproate, if taken by a mother, then it may cause fetal hydantoin syndrome. If patient the taking is valproate, then it may cause spinal dysraphism, okay, meningomyelocele or other spinal abnormalities. So we have to take the pregnancy also into consideration, and individual lifestyle. For example, if you give a drugs which has to be given 3 times a day to a college going student, he may not take it. So you have to give a drugs which can be given either once in a day or twice in a day. So we have to take all the things into consideration before starting anti-epileptic drugs. Then anti-epileptic drugs factor means what is the spectrum of efficacy. For example, sodium valproate is a broad spectrum, so you can use if there is a different type of seizures, or if you don't know which is the type of seizures, then you can use sodium valproate. And if you know that it is a focal onset of seizures, then you can use carbamazepine or sodium valproate, phenytoin sodium. Mechanism of action, for example, certain drugs act on sodium channel, so you cannot use the drugs which acts on sodium channel in an epilepsy which is caused by sodium channelopathy. For example, if the patient has, say, Dravet syndrome, you cannot use phenytoin sodium or carbamazepine or lamotrigine. So mechanism of action is very important. Indication is also important. Why are you treating these patients? Okay, tolerability and safety, this is very important. We have to treat with a minimum side effect. So if patient is non tolerating, then you have to change the drug. Then neuropsychological implication, for example, certain drugs may cause hyperactivity, so you may not use in a school going children, like phenobarbital or levetiracetam or clobazam. These drugs may cause hyperactivity or problem in learning, so you can avoid this kind of drugs in these patients. Dosing frequency, titrations, and simplicity of use. So I have discussed that once in a or twice in a day dosing increase the compliance. Drug interaction, so you cannot use drugs which interact with each other. For example, phenytoin sodium and carbamazepine have action on sodium channel, so you cannot use both the drugs because they act, and then it will increase the side effect because they have a same mechanism of action. So if you have to use 2 drugs, preferably use a drug with a different mechanism of action. Teratogenic potential, for example, sodium valproate, carbamazepine, phenytoin sodium has a teratogenous effect, while levetiracetam has a less teratogenic effect. So this is preferred if the woman is planning pregnancy. Then of course availability and cost, because the new anti-epileptic drugs are costly while the old are cheaper one. Now, depending upon various syndrome, we can use various drugs. So we have discussed all these things. Now, how to use a drug in case of epilepsy? You diagnose that this patient is an epilepsy and require anti-epileptic drug, then you have to start an appropriate drug taking into consideration all these factors: age, gender, ethnicity, type of seizures, comorbidity, and the cost. And if you start one anti-epileptic drugs, then increase its dose till seizures is controlled or side effect occurs. Okay, and once seizure is controlled, then you have to continue these drugs at least for 2 to 4 years, seizures free period. One has to usually give only single drugs, monotherapy is preferred. But sometime if you give one drugs and seizure doesn't control, then you add on you give other drugs and taper and omit the first drug. Okay, but if you give one drug and seizures are reduced partially but not completely, then you continue the first drug and add on the appropriate second drug. So this is called as rational polytherapy. When the patient is on anti-epileptic, you have to monitor these patients every 2 to 3 months to see whether there is any side effects. For example, certain drugs may cause drug rashes like phenytoin sodium or carbamazepine, or it may lead to Stevens-Johnson syndrome. So you have to caution the parents that if there is a rash, then stop the drug, show to the doctor, and change the anti-epileptic drugs. So this is very important. So certain drugs have a certain side effect which you have to monitor, like valproate may cause weight gain, topiramate may cause weight loss, topiramate may cause word finding difficulty, decrease in cognition, topiramate and zonisamide may cause peripheral paresthesia, topiramate may cause renal calculus. So you have to monitor UHG every year to see whether there is any renal calculi. Then there may be a concentric visual field restriction after vagibatrin. So you have to give vagibatrin only for 3 to 6 months and monitor their vision. Osteoporosis like valproate or cytochrome P450 enzyme inducer like phenytoin sodium carbamazepine. So you have to supplement them with vitamin D and calcium. Or carbamazepine may cause hyponatremia. Valproate may cause hyperammonia or encephalopathy. So when you are starting valproate, ask the parent that if there is excessive vomiting, lethargy, or jaundice, then you have to stop valproate. Closed angle glaucoma may occur because of topiramate. So if there is some vision loss, or there is a difficulty in seeing, or there is a redness of eyes with topiramate, then we have to caution the parent then to stop it. Certain drugs may cause rash like carbamazepine, lamotrigine, phenobarbital, or phenytoin. So how long we have to give anti-epileptic drugs? If patient is neurologically normal, EEG is normal, MRI normal, seizures are easily controlled, then we continue drug for 2 years, and after 2 years we do EEG, and if EEG is normal, then we slowly taper and omit drug over a period of 3 to 6 months. Okay, but if there is a symptomatic epilepsy, means the epilepsy is caused because of some previous injury to the brain, then we continue anti-epileptic drug for 3 to 4 years. Okay, and then we slowly taper and omit. Now what you have to do when seizures occur? This is very important. We have to guide the parents and tell them what they have to do when seizures occur. When seizures occur, the patient has to the patient should be put in a very safe and comfortable environment, in a lying down position, with in a left lateral or right lateral position, or in this prone position. There is a lot of misconception what to do during seizures in public. Some people may put like a spoon or handkerchief or finger in the mouth to open the clenching of teeth, or they may they may held some chappal or shoes in front of the patient's nose. They may put a water in the patient's mouth, but this is all the wrong things. One has to be extremely cautious and not put anything in the mouth. Okay, don't put anything in the mouth when seizures occur. Keep the patient in left lateral or right lateral position. Loosen his cloth. Do not gather around the patient. If the patient is having seizure, do not try to restrain the patient's seizure. Usually seizures are controlled within 2 to 3 minutes. If seizures are not controlled within 2 to 3 minutes, if seizures are prolonged, then take this patient to the hospital. We usually advise parents what to do, what medication to give during seizures. And nowadays, initially and now also rectal diazepam we used to give to the parents so that they can use at home whenever seizures occur. But nowadays nasal midazolam spray is available. So if seizures occur and it lasts more than 5 minutes, then we advise parents to use intranasal midazolam. If the seizures are not controlled with 2 or 3 anti-epileptic drug, we called it as a drug resistant epilepsy. And if it's a drug resistant epilepsy, then we again go back, see whether the patients truly have epilepsy, whether patients has a seizures mimic. If it is a seizures mimic, then you may give a lot of drugs, but it won't be controlled with anti-epileptic. So go back whether your diagnosis is correct, whether the patient is taking medication or not, whether you are giving appropriate medication, if there is underlying progressive condition in a brain. So all these things need to be clarified before declaring the patient as drug resistant epilepsy. And if there is a drug resistant epilepsy, 70% of the patients are controlled with drugs and 30% patients do not control with drugs. So this patient may require epilepsy surgery or ketogenic diet or vagus nerve stimulation. So these are the different modality of treatment as far as epilepsy is concerned. Ketogenic diet is a diet which contains predominantly fat and very less carbohydrate and protein, no carbohydrate and adequate proteins. Okay, so this diet is given if the patient, especially children, do not control with drugs. Surgery, if there is a lesion in the brain or tumor or there is a malformation and it is causing seizures, then by removing that lesion the patient may become seizures free. So we have seen how to diagnose and approach a patients with epilepsy. First is a history taking and examination. After taking history and doing examination, then you have to diagnose whether it is a epilepsy or it is a seizure mimic. If it is a seizure mimic, then treatment is different. If it is a seizure, then you have to classify whether it is a focal or generalized seizure, then classify them into syndromes, then investigate simultaneously by doing EEG, MRI or blood investigation or lumbar puncture. Once you diagnose that it is a case of epilepsy, then you start anti-epileptic drugs, continue for 2 to 4 years. If patient is not controlled with one drug, then taper and omit one drug and add other drugs. If patient is partially controlled, then add on appropriate second drugs. Continue this drug for 2 to 4 years depending upon the cause of seizures. If they are seizures free, then try to taper and omit the drugs. If seizures occur, teach the parent what to do and what drugs can be given during emergency, like nasal midazolam spray. Monitor the patients for the side effect. Okay, give them love, support and education to the parents, because there are a lot of misconceptions about epilepsy in this society. Epilepsy is considered as a taboo. There is a misconception in society that the epilepsy is because of they have done certain bad things in a previous life, or it is wrath of a god, it is a communicable disease. So these are all misconceptions, and because of this misconception, this patient has kept away from the treatment. So this, what is required is awareness about this epilepsy in the society, so that these patients are taken to the appropriate doctor, diagnosed at appropriate time, and start medication, because 70 to 80% of the patients are controlled with anti-epileptic drugs, and remaining may be offered surgery, ketogenic diet, and other modality of treatment. And this patient can have a very normal life, they can marry, they may have children. So we all need to spread the awareness of this disease in the society, remove the taboo, misconception, support these patients with love, compassion, and try to integrate in the society. Thank you so much for your kind attention. Hope you have understood. If you have any query, you can contact me on my email drsbsable79@gmail.com. And hope you and your family is safe in this corona pandemic. Take very good care of yourself. Wear a mask, have social distancing, eat healthy food, do yoga, pranayama, meditation to keep you fit and healthy during this corona pandemic. Thank you so much for your kind attention. Have a wonderful day.